Good afternoon. So today we are going to discuss about anticholinergics. So we have several drugs which work against several receptors, and anticholinergic drugs are very fundamental drugs used in clinical practice. So prior to that, acetylcholine is kind of a neurotransmitter which is more or less it the action of it is either excitatory or inhibitory, which depends on the system. For example, on heart, the acetylcholine has an inhibitory action, but in the GI system it has an excitatory action. That means it decreases the heart rate, but it increases the gastric mortality. Similarly, it has also a role in muscle contractions. In the current clinical practice, a very good role in anti-Parkinsonism drugs. So once we talk about any drug specific to any neurotransmitter, for example, when we go to the acetylcholine, we will talk about cholinomimetics. Then we will talk about anticholinergics. So there is nothing like that will directly give acetylcholine. For example, we have direct prototype of dopamine, although it has a very low elimination half-life, but we have dopamine, which we can inject directly, usually given in case of shock or cardiac arrest. But we don't have anything like acetylcholine, which we are going to directly inject. So maybe we have it chemically, a chemist can make it, but yeah, it does not have that clinical role. But when it comes to uh, cholinergics or anticholinergics, we have drugs which mimic the action. For example, any drug which will mimic the action of acetylcholine, we call them as cholinomimetics. Something which mimics the action of GABA, we call them as GABA mimetics. Some drugs which mimic the action of adrenaline or noradrenaline, we call them as sympathomimetics. So once we go with the uh, anticholinergics, we should understand fundamentally that they are the drugs which block the cholinereceptors, and these drugs have very important clinical value. And once we have to recall it from the basic pharmacology that these cholinereceptors are divided into two main broad categories. One are the muscarinic receptors and the nicotinic receptors. All are divided equally, M1, M2, M3, M4, M5. And in case of nicotinic receptors, we have two nicotinic neuronal receptors, or N1, or nicotinic N2, or NM, NN or NM, nicotinic muscular receptors. So these are broadly classified into muscarinic and nicotinic. Why? Because the actions are similar. Actions of acetylcholine are similar to that of muscarine or nicotine, right? Some actions relate with the muscarine and alkaloid. Some actions relate with another alkaloid, nicotine, right? So conventionally, all anticholinergic drugs are those drugs which block the actions of acetylcholine autonomic effectors and in CNS, which is exerted through the muscarinic receptors. Similarly, we have nicotinic neuronal antagonists, which we call as ganglion blockers, and we have nicotinic muscular, which we call as neuromuscular blockers. And I have discussed it in earlier lecture regarding depolarizing and non-depolarizing neuromuscular blockers. The prototype drug is atropine. It's very synthetic and semi-synthetics are available, and atropine semi-synthetic drugs are also available. They are all competitive antagonists, and usually guinea pig ileum, it's a part of the intestine, is used for its effect for demonstration. You might be well aware about the organ bath assembly, so where we check the action of a certain drug. Now, once you go about the anticholinergic drugs, we we classify them on the basis of yes, we classify them uh, on natural and semi-synthetic derivatives. We have they we have atropine. It is isocyanated or scopolamine. Then we have homoatropine, atropine methonitrate, isocene butyl bromide, ipratropium bromide, tiotropium bromide. So they are all semi-synthetic derivatives. Then we have mydriatics, which dilate the pupil, cyclopentolate and tropicamide, very good drugs used in ophthalmic surgery. Then we have anti-secretory antispasmodics. They have anti-secretory plus they also uh, prevent the muscle spasms, in which we have tertiary amines like dicyclomine, and we have quaternary ammonium compounds like propenthyline, oxaphenaminium, glycopyrrolate. Very good drug which is used prior to surgery. Initially, we used atropine, but now glycopyrrolate has very low action on the receptors of heart. So we have an anti-secretory action. We can go for inhalation anesthesia, and more or less we have a benefit that it is not going to affect the heart. So we don't have to look for that tachycardia thing, which will be caused by the normal atropine. Similarly, we have vasoconstrictive drugs which act on the urinary bladder. Glyphosate is very commonly used in clinical practice as an anticholinergic, antispasmodic drugs. Then there are some anti-Parkinsonism drugs like trihexyphenidyl, procyclidine, piperidine. Although with the use of certain new drugs like levodopa, carbidopa, and amantadine, and some other drugs, we use them very less. But yeah, in acute episodes of Parkinsonism-like symptoms, which may or may not be caused by antipsychotics, we have a very good role. Like benzotropine is one among benzotropine. Additionally, we have TCS, tricyclic antidepressants like nortriptyline, amitriptyline. They all have an additional action of blocking the cholinergic receptors. Phenothiazines, including promethazine, uh, comes as a brand name of Avomine, used as an in motion sickness and vomiting, and it also has a very good sedative effect, antihistaminic effect, but additionally it has a good anticholinergic effect. So antihistaminics I discussed, phenyramine, basic antihistamine. It is a very good anticholinergic drug, I'm telling you. So promethazine, phenyramine, so they all come under the anticholinergic spectrum. Why? Because they have an additional action. So in our clinical practice and in basic pharmacology, we call them as off-receptor effects. Off-receptor effects means they have an additional off-receptor effect. That is, they primarily are doing some other work. They are meant to block the actions of antihistamine. But since every drug is not very specific, like now we have levostrazine or we have cetirizine, we have fexofenadine, loratadine. They have very low anticholinergic actions. They are very specific for antihistamine. But earlier we didn't have. We have an antihistamine, but it has off-receptor targets also. That means it will target the histamine receptors as long as they will target the cholinergic receptors also. In fact, they also target some serotonin receptors also. Anyways, that's a separate topic to discuss. But yeah, they have anticholinergic effect. Next, atropine. It is found in the plant Atropa belladonna or deadly nightshade. Similarly, it is also found in datura. I have seen in clinical practice datura poisoning. Scopolamine. It's found in Hyoscyamus niger, and that's it. Now, chemistry. It both are from tropic acid, aromatic acid plus tropine, and tropic acid plus scopine. So mostly actions are similar. Else then scopolamine has a very it has a direct action on all the five receptors, except that it has very low specificity for M1 receptor, the receptors of heart. Okay, probably M2 receptors. Okay, right. So next is the mechanism of action. The atropine causes reversible or surmountable. Now here is a um, it's M2 receptor to be more specific. Okay, I was searching it. It's M2 receptors. It is in the heart, in the myocardium and SN. So it causes surmountable blockade. That means surmountable means it's a very good pharmacological term. That means any blockade, because since it's a competitive receptor blockade, right? It competes for the natural neurotransmitter. So it's kind of a race. So neurotransmitter uh, will race with this kind of a molecule. Because anyways, fundamentally, what is an antagonist? An antagonist is something which has an affinity for the receptor, same as that of an agonist, or same that as that of a neurotransmitter. But what? Its efficacy is zero. It blocks the receptor. So it's a complete receptor blockade. So surmountable means that it can be overcome. We can overcoming how? We can increase the concentration of agonist, right? So then without decrease in the maximal dose response, reduction in the maximal response. Okay. Why? Why is it surmountable? Because this type of blockade we can overcome by increasing the dose of agonist. Why? Because they are in the competition and their binding site is same. It's not like any kind of an allosteric modulator or something else. They are binding to the same site. So blockade by a small dose of atropine, they can be by increasing, so like it has mentioned it. So it's very highly selective for muscarinic receptors. It does not distinguish as a non-selective competitive blocker. It blocks all the five receptors. Okay, and they have we have some anti-muscarinic agents which also have a kind of ganglion blocking actions. That means they act on mm, nicotinic receptors as well, right? Now we go into the pharmacokinetics. Its absorption, the natural alkaloids and tertiary antimuscarinic drugs, they are well absorbed from the gut, from the conjunctiva, and it has also skin absorption also. Okay, it can penetrate cornea freely. Atropine is highly and widely distributed in the body. Scopolamine is distributed in CNS, and it has a very greater action than any other antimuscarinic drugs in the CNS. And then metabolism, it is metabolized in liver by conjugation, and 60% excretes unchanged, right? And effects will disappear quickly within 2 years, except eye. Preparations are intramuscular, intravenous, oral, transdermal. In fact, I have went into subcut administration of atropine before any surgery in my clinical practice. Now, pharmacological actions. Overall, it is a CNS stimulant, atropine. At low doses, it has only peripheral effects because it does not cross blood-brain barrier at the low doses. It has minimum stimulant effect on the CNS. But scopolamine has a very central depressant effect. It causes amnesia, drowsiness. Atropine also stimulates other centers, vagal center, respiratory center, uh, vasomotor center. It has anti-motion sickness property. That's why I'm telling you, scopolamine or hyoscine butyl bromide is well used for motion sickness. Very good drug. It also blocks ganglia cholinergic overactivity. It can block the tremor, rigidity, although it's not a fundamental drug for that. Now, on the central pharmacological action of atropine on central on the cardiovascular system. So it's a M2 blocker. I told you that acetylcholine has an inhibitory action on heart, so this will have an excitatory action. It blocks, so it increases the heart rate. It causes tachycardia. So that's why it's also used in some heart blocks. We use it. Okay. So blockade of M2 receptor on SA node, the vehicle tune decreases heart rate. Higher the vehicle tune, more bradycardia. Sometimes it can have also inhibitory or excitatory, so you will never be sure. But at moderate and high doses, it's tachycardia, right? Uh, Atropine abbreviates the therapeutic period of AVN, facilitates AV conduction rate, reduces PR interval in ECG. That's all something to be discussed further. Uh, with intramuscular and subcutaneous injections, initially you will have a transient bradycardia. That's why I always tell my fellow friends whenever I was there in the clinics, that initially if you will give it, it will not directly cause the tachycardia. That's what is aimed for sometimes in a block. Why? Because initially it causes bradycardia. Why? Because it inhibits the pre-junctional postsynaptic M1 autoreceptor. Okay, so that's a very different thing. Because of that M1 autoreceptor inhibition, uh, not because of M2 receptor blockade. There is the stimulation of vagal center. So because of that effect, initially you can see bradycardia, but once you increase the dose, you will see. Uh, on BP, it has no constant effect. Tachycardia, VMC stimulation raises BP, but histamine release and direct vasodilation action counter it. So that means even if it increases the BP, there is a compensatory mechanism out there. There is histamine release and there is also direct vasodilatory action. Okay. Now in eye, it is a mydriasis. It causes mydriasis. We have topical atropine and other antimuscarinic drugs, which uh, result in unopposed sympathetic dilator activity. That means because of any sympathetic system, because of adrenaline, the effect can't be counteracted. Okay, so it causes mydriasis. That means it causes, yeah, it dilates the pupil. That's why in case of a disease called as glaucoma, we avoid these agents. Why? Because they increase the intraocular pressure. Cyclopegia, abolition of light reflex. It's very desirable in ophthalmology. You can abolish the light reflex by this. Photophobia and blurring of near vision. IOP rises. It's very hazardous in narrow angle glaucoma, as I told, and in dry eye, it's not desirable at all. But yeah, it has a very good therapeutic role in eye surgeries and ophthalmic examinations, that you have to go for a physical ophthalmic examination, directly give the atropine, it will dilate the pupil, and you can, as an ophthalmologist, so it has a very good role. This is the dose response curve of effect of scopolamine on ciliary muscles. So next is atropine on smooth muscle. Okay. So on respiratory system, it causes bronchodilation. Uh, it decreases the airway resistance. It is very it was used earlier, but nowadays we have some inhalation agents like epatropium. We use them as nebulizers. So because since it is a very non-selective competitive blocker, so we usually don't prefer it. So I don't know if we can nebulize atropine also, but yeah, if we nebulize it, it has all direct excited reaction on the heart. So it's used in COPD, chronic obstructive pulmonary disease, and asthma patients. It also antagonizes vagal mediated overactivity due to histamine, right? And prostaglandin leukotrienes. It has a direct and antagonistic action on all those pro-inflammatory molecules. In case of urinary system, it is a, I told it's a vasoselective drug. It it releases the relaxation of ureter and bladder, urinary structure in older males with benign hyperplastic prostatomegaly. In BHP, it's very highly contraindicated. Okay, right. So sometimes we can use it in increasing bladder capacity and controlling the retrostatic hyperreflexia, neurogenic bladder neurouresis. Similarly, in visceral stimulation, there is a relaxation mediated by M3 blockade sometimes. So tone and amplitude of contraction of stomach and intestine are reduced because of M3 blockade, right? So you have to sit it. That is a potential there for anti-spasmodic. It also reduces the passage of chyme. It can cause constipation and also relief of spasms. But yeah, it has less peristalsis suppression. So indirect nervous system, more effective to exogenous acetylcholine administration. Now on glands, it is I told you earlier that glycopyrrolate or atropine, any anticholinergic drug, they are anti-sialogogues. So they decrease the saliva. They also decrease tracheobronchial secretions, lacrimal secretions, sweat. So the common effects you will observe because of anticholinergics is dryness of mouth, dry skin, conjunctiva, difficulty in talking and swallowing. In stomach, primarily because of M1 receptor blockade, it decreases the acid secretion. And we have a very typical drug in that. It's called clidinium bromide. It's also an anticholinergic. It's very specific for M1 uh, with no M2 or any other activity as well. It decreases acid, pepsin, mucus secretion. Why I'm telling you decrease acid secretion? Because acid has three pathways. We have a someone called as proton pump inhibitors, where we directly block the proton pumps. Then we have anticholinergic drugs, and at times we have also antihistaminergic drugs, H2s. So we have three drugs. I will discuss that part in a different lecture, but right now you remember that we can block the acid secretion in three. One is the proton pump inhibitor with golden standard, less side effects. Second is you can use any anticholinergic drug. I'm telling you, clidinium bromide also decreases acid secretion. And number third is you can use any antihistaminergic drugs like ranitidine, samidine, or something. So it decreases mucus secretions, pH of gastric contents may increase in empty stomach. pH not interfere. It also decreases bicarbonate secretion. Atropine is less efficacious than H2 blockers, as I was said. It has minimal effect on intestinal and pancreatic secretion, and it has no effect on bile production. Now the pharmacological actions, it increases the temperature, decreases sweating, and stimulation of thermoregulatory centers in hypothalamus. It has local anesthetic action on cornea. It enhances acetylcholine and noradrenaline release. It's a paradoxical phenomena. Different things I can discuss it, but yeah, I need a time for that sometimes. So sensitivity for organs, saliva, sweat, bronchial secretions, then smooth muscle of intestine, then bladder, gastric gland, and smooth muscle. Now we have semi-synthetic atropine derivatives, mydriatics, antispasmodics, and bronchodilators. So those are the ones which we use, and we localize them for that only specific action. Since atropine is something which will block all the receptors, so we don't need that. We need some mydriatics, like which increase the intraocular pressure, antispasmodic, decrease the muscular spasms, smooth muscle spasms, bronchodilator, open the like increase the decrease airway resistance. So these for peripheral action only, they have incomplete oral absorption, they have poor CNS and high penetration, they are slow elimination, they have higher nicotinic blocking property, they are neuromuscular blockades at high doses. So in this high butyl bromide, it's a very good drug for used in irritable bowel syndrome in humans also. So it's used in esophageal and GIT spastic conditions. Buscopan, it's an oral drug also, and intramuscular also. Buscogast or Buscopan. Then we have atropine methonitrate. It's used in abdominal colics. It's also available as oral and intramuscular. IPA, ipratropium bromide. It's a very selective action on bronchial smooth muscle. So it causes its dilatation. So it does not alter volume and consistency of respiratory secretions. Does not alter that. It enhances the mucociliary clearance, which is very contrast to atropine. It does not do that. And in case of ruminants, we have seen that atropine does not decrease the secretions as well. It makes the secretions more viscid. I'm telling you, it makes them more viscid. So we usually never go for atropine in ruminants when it is meant to induce any kind of gaseous anesthesia, because we know it very well. So always when we go for ruminants, we initially go for example, diaphragmatic hernia is a condition where we individually always go for ruminectomy to decrease the gas, and then there is no point of using atropine there. But yeah, we can use it at lower doses for antispasmodic actions. But yeah, when it comes to the clearance of respiratory secretions, it makes them more viscid. But when it comes to ipratropine, it's used as a nebulizer. Uh, it's very slow acting. Uh, the onset is slow, but the peak is very late. It is bronchodilator action 1 to 2 hour. You can use as prophylactic also, which is contrast to sympathomimetics. But as a nebulizer at therapeutic levels, at therapeutic dose, like when we have a condition of having what we call as a condition of breathlessness, you can directly use it. It is more effective in COPD. It is more effective in asthma. Uh, we the adverse drug reactions include cough, bad taste, rare systemic effects. Then there is another tiotropium bromide, and it's longer acting and more M1, M3 selective. Right? We have some quaternary compounds like propantheline. It is used in peptic ulcer disease and gastritis, but nowadays anticholinergic are rarely used in that, except clydinium, which is used in nervous dyspepsia, gastritis, IBS, colic. Then glycopyrrolate, which is rapid acting without central effects. So very good pre-anesthetic medication. When we go for gaseous and we have to reduce the tracheobronchial secretions, we go with glycopyrrolate, although very costly drug. Oxyphenone, peptic ulcer, and gastric hypermotility. Then we have some tertiary amines like dicyclomine, valethamate, and pyrazipine. This is smooth muscle relaxant and antispasmodic, very weak anticholinergic activity, lesser side effects because it has lesser side effects than atropine. It is antiemetic, used in morning sickness, but very less specific for that. Uh, so atropine toxicity in infants, that's why we go for dicyclomine. It's a very common anticholinergic drug, Abrospas or something, very locally available in dysmenorrhea and irritable bowel syndrome. We go for sometimes we go for triple therapy like clydinium bromide, dicyclomine, and chlordiazepoxide. Okay, that's a different topic as well, but yeah, I'm telling you that these are the combinations used. Then we have valethamate. Oh, nowadays not available in the market, but yeah, it was used earlier in dilatation of cervix and related labor. It's a visceral antispasmodic. Then pyranozapine derivatives, we have selective M1 antagonist, which has no action on M2 and M3 receptors, no atropinic side effects. It promotes ulcer healing. It is less popular. I'm telling you, anticholinergics are very less popular now when it comes to use in the peptic ulcer because we have better options available there. PPIs PPIs totally became a game changer. Now we have ASCO selective drugs still used. For example, oxybutynine. It has a very selective for urinary bladder and salivary gland. Additionally, it has muscle relaxant property and local anesthetic property also. It is used in detrusor instability, spina bifida, and nocturnal enuresis. It's very common in child, but nowadays we have, since the onset of tricyclic antidepressants, we also exploit them for their anticholinergic activities, but they have a bigger role of action, like desipramine or imipramine. Imipramine is used it's a much better drug than oxybutynine in nocturnal enuresis, and it's also used in neurological disease, involuntary voiding in patients, in bladder surgery. Simply, second drug is tolterodine, used in urinary urgency overactive bladder, but nowadays not used because I'm telling you again, overactive bladder, we have tricyclic antidepressants and very good drugs. Flavozate, very similar, but yeah, used. Then we have drotaverine, but yeah, it's not anticholinergic. It is an antispasmodic. It works by inhibiting phosphodiesterase 4 enzyme, which increases the cyclic AMP levels and then causes smooth muscle relaxation. So it's a very good drug, rotavirine. It has no anticholinergic. Nowadays, we are looking for the options having no anticholinergic effects but antispasmodic actions. Why? Because anticholinergic, this side effect of dry mouth, dryness, uh, it's usually a kind of a headache for the patients. Now, atropine is slow and long lasting as Medriatic, cyclopegia 1 to 3 hours, duration of action 7 to 10 days. Then we have for pre-anesthetic, we use glycopyrrolate. Why? Because we decrease the tracheobronchial secretions to make gaseous anesthesia very pleasant and safe. We usually had ether, and ether is a very good anesthetic, was a very good anesthetic, but it got stopped only because salivary and tracheobronchial secretions. It used to increase it. So it is also used in halotene-induced ventricular arrhythmia in vagal slowing down. It also prevents laryngospasm. These respiratory secretions cause laryngospasm. So when we decrease them, so we prevent the laryngospasm. In peptic ulcer disease, in pulmonary embolism, and in hyperhidrosis, condition where there is increased sweat production, only when you have ruled out other causes. Now, as antispasmodic, I told you earlier, intestinal renal colic, diarrhea, spastic constipation, IBS, pylorospasms, gastric hypermotility, dysmenorrhea. And dysmenorrhea, earlier you listened about mephtal spas, no? Contains dicyclomine and mefenamic acid. Dicyclomine is what? It's an anticholinergic. Now, in reflex vagal activity, bronchoconstriction and increased excretion in bronchitis and COPD, lesser in asthma. So, in bronchoconstriction, we use it. In increased excretions, we also use it in bronchitis. But in asthma, nowadays they are not used, but yeah, they had a use. In nebulization, we still use ipratropium bromide. You can go with oral atropine bronchodilation. The disadvantages are dry obstructions in respiratory tract, inspations, plugging in bronchioles, collapse, decreased mucociliary. Now, inhalation ipratropium bromide, it does not decrease secretions. It does not impair mucociliary clarity. It's very useful. So yeah, I have tried it on several animals. It's a very good drug. It can use to for regular prophylaxis. That means we can use it prior to the asthmatic attack. Now, Mediatic and cycloplegic ophthalmic uses. For diagnostic purposes, for ophthalmic examinations, atropine 1% ointment is used. Uh, for therapeutic uses, we use it in iritis, iridocystititis, keratitis, corneal ulcer. Why? Because you want to decrease the secretions. But yeah, not that therapeutic value these days. Now, on cardiovascular system, it can be used in myocardial infarction. It can be used in digitalis toxicity to counteract that reflex vagal bradycardia. Do you know that reflex vagal bradycardia? Digitalis, initially, what is it? It is a inotropic drug, right? It increases the contractions, but it can cause reflex vagal bradycardia. So to decrease that, we can use this. In Parkinsonism, mild, and it's used as an adjunct therapy to levodopa. But directly, you don't use atropine, right? So we basically try some newer drugs like benzotropine is one of the drugs. In motion sickness, very good. Hyoscine butyl bromide is used. Oral injection, transdermal patch, anything. Or you can give it as prophylaxis, zero point 0.2 mg given orally. Sedation and amnesia to a light sleep. It is used for mushroom poisoning, anticholinergic mushroom poisoning to block muscarinic cobra envenomation, and to block the effects of neostigmine also. Now, adverse drug reactions, they are occurring, but non-serious type. Anti-secretory action is pre-anesthetic medications. Now we have belladonna poisoning. If you use belladonna or datura, so rapid pulse, convulsion, coma, hypotension, dilated pupils, photophobia, psychotic behavior, delirium, all such effects can be seen. They are non-specific, although, but yeah, they can be seen. In belladonna poisoning, we usually go with methacholine 5 mg or neostic 1 milligram subcut. It has no NASCAR. I told you, it's a cholinergic drug. So I told it's a surmountable blockade. So we increase the action of cholinergic, so which will decrease the action without decreasing the maximal dose response. Uh, in belladonna poisoning, I can still mention it. I have just added these slides because I wanted to cover the entire anticholinergic system and this. Uh, Initial treatment is gastric lavage. Then we have physostigmine. Then you have to maintain the adequate blood volume. To control convulsions, you have to use diazepam or other ganglion blockers, right? In glaucoma, it's contraindicated, narrow angle glaucoma. In benign hyperplastic prostatomegaly, it causes urinary retention. It's very contraindicated in that. And in peptic ulcer disease, nowadays non-selective, it can cause precipitation of symptoms, right? Now we have drugs acting on ganglions. I think we will discuss it in the next lecture. Thank you.